I am Stephanie Quinn. I am the Senior Vice President of External Affairs and Practice Experience at the American Academy of Family Physicians. Thank you, Yalda. That was not terribly uplifting, but I am confident that this next panel we are going to start digging into some folks who are really looking at how they can be working to increase the primary care workforce. With me today, I think they're on. With me today, I have Joyce Knestrick, who is the past president of the American Association of Nurse Practitioners. I have Dr. Millard Collins from the Meharry Medical School, and I have Dr. Sherri Morgan from HCA Physician Healthcare Services. So with that, I think I'd like to start off by asking each group to just give a high-level flyover on things your respective organizations are doing to address the primary care workforce and growing the workforce. Can I start with you, Joyce?
Sure. At the American Association of Nurse Practitioners, we're working to break down barriers to NP practice across the United States. We know that we have made some strides in working on reducing those barriers. We still, like physicians, have low reimbursement rate for primary care, which is an issue. We have about 385,000 nurse practitioners in the U.S. We think about 85% are certified in primary care, but we think that about 70% actually practice in some form of primary care. So even though we have people on record that look like they're doing primary care, they're probably working with a specialist in some form. And so we're working to increase the number of people who are out in primary care because we have a commitment to serving, rural, underserved areas. And so we are always looking at focusing on those areas to help increase our workforce.
Good afternoon. At Meharry Medical College, I don't know how many of you are familiar with it. It was originally founded in 1876 to address the underserved, and since that time we've done that as that definition has expanded from minority patients to now immigrants, now addiction, correctional facilities. But in addition to that, we also, in my opinion, we address the nation's need for more diversity in the healthcare workforce. We have a School of Medicine, a School of Dentistry, a School of Graduate Studies and Research, and a pretty new School of Applied and Computational Sciences. Despite the cost of medical education, our residents, our students, when they match, about 50% of them actually still do go into primary care. And a lot of that is because we, as much as we can, offer funding support, so funding dollars to try to mitigate the cost of medical education goes a long way. But I have to acknowledge that despite 8,000 applications, the admissions team really looks for students that want to have the Meharry experience and go into primary care, serve rural Tennessee. And that's something that's just been important. Just because I'm biased doesn't mean it's not true, but I think primary care physicians are the greatest physicians in the world. I think we can treat 90% of whatever comes in through the door. But as has been mentioned already, some of the struggles that we have, the value-based compensation was a great idea in theory, but when you serve in underserved populations and rural populations, you have a different starting point. And many of those traditional physicians don't have the infrastructure to really close those care gaps. And as a result, they're having to close their doors and find alternative means to make the change that they want to make. But that's just a little bit about what we do at Meharry.
Great. What about you, Sherri?
Good afternoon. Sherri Morgan. First of all, I'm a family medicine physician. I am from Columbus, Ohio, trained in Mount Carmel. And the reason why I mention that is because I'm very proud to be a family medicine physician, even though I'm currently not practicing. I work with HCA Healthcare, and I started with them back in 2018. The reason why I started working with them was to be in a strategic role to help design, develop, and maintain high-quality GME programs. And one of my passions, my primary passion, is family medicine. And so we currently have 30 family medicine programs across 17 states. And you may say 30 is not really big, but for a hospital health system, that's a pretty good size. They're all community-based programs. And we trained about 636 residents. We're going to graduate 205 residents coming up. We graduate in June. We expect to graduate about 250 next June. And so we were always looking at ways of maintaining connection with primary care training. We also have IM programs and we have pediatric programs. The goal with graduate medical education is training the next generation of physicians. And so my goal in this role is to strategically help develop these programs, not to just meet the ACGME requirements, but to provide them an interdisciplinary training model where they can do great tertiary care in the hospital, learn how to work with our health providers like PAs and nurse practitioners, really know how to take care of a patient in a tertiary aspect, because some family medicine physicians actually want to do hospitalists and want to work in the hospital. But also my biggest passion is ambulatory continuity clinics. I was a medical director before I was a program director. I worked in private practice. I worked in a FQHC for a while. And so my pride and joy is the strength of our continuity care clinics, which we have optimized them to be real world. We have a great EHR. We run our clinics just like the real world. There's no longer our residents are doing things that they shouldn't be doing because doctors don't really do them. We have MAs. We have PAs, we have nurse practitioners, so we train them in a real world model. The goal is when they graduate, we want them all to go out and do primary care. But we also want them, more importantly, be connected to their community, feel like a part of their community, and really have a positive view of primary care. And that's the one thing I have to emphasize. There is no putting down family medicine. There is no negativity. We train all of our specialties. You're all one big team. And that's the biggest thing that I push with HCA is in their hospitals, you're all a physician, you all play a role, but primary care we know is important. We have to keep people out of the hospital that don't need to be there. The costs are getting ridiculous. We have to keep them out of the ER. The only way to do that is primary care.
Thank you. And I could take that a lot of different places, and hopefully we'll touch on all of them. But Millard, I want to pick up on something you said around technology. How are your organizations leveraging technology and bringing that into your efforts to attract and recruit a workforce?
Well, these kids, I call them kids, they're very technologically savvy. And in COVID, we really had to get pretty creative, starting with telemedicine. Telemedicine has kind of been around, but I think it's been catapulted into the forefront. And you know, we need more consistency across our payers to reimburse the physicians for still being able to deliver that high quality care. You know, remote patient monitoring, you know, devices such as that really empower the patients to be aware of what's going on in their bodies in real time, I think is something else that we've really been promoting. We have lots of great partners. HRSA has been a partner to help us really try to expand the workforce and across a myriad of primary care related specialties, behavioral workforce, geriatrics, primary care. And I've been fortunate as a department chair having millions of dollars that have been invested into the opioid epidemic. You know, opioid addicted patients don't always look a particular way. And we're starting to learn and hopefully get more comfortable dealing with those patients. And telemedicine has been a great vehicle to do just that. We're excited about the promise of AI. AI is really something that's really helping our physicians to meet those needs and avoid burnout. One thing we haven't talked about yet is burnout, you know, and so much is put on the primary care physician to see patients every 15 minutes, you know, teach students and residents, and then complete your charts. Are you going to get an ugly deficiency letter? I think it's stressful, and we're looking at some really cool possibilities of an AI device being used to listen to the encounter and help to generate a progress note, to enhance billing and things of that nature. And I think it's just going to really make primary care that much more attractive when we take advantage of the technology.
And Sherri, are you finding that your incoming workforce, that they're ready to use those tools, or are you teaching them about, you know, how to integrate these new innovations into their practice?
Most definitely. First of all, the ACGME requires that, but we go beyond that because healthcare systems, you have to be ahead of the game. And so we have simulation, some beautiful simulation centers within our hospital. We have some nursing centers with some great simulation, particularly in Dallas, but our simulation centers for our residents are maintained in the hospital. So for primary care, internal medicine, family medicine, across the board, all of our specialties have simulation. We've invested a lot in terms of new technology. We're looking at Google Glasses. Right now, we're looking at surgery using them, but also too, primary care. And so the residents coming out, the medical students coming out now, their brains are wired. We're talking at the table, their brains are wired differently. They've been in front of an iPad since what, 3 months, 2 months old? So their brains are wired differently. And so to put them in front of a bunch of paper, that does nothing for them. They want technology, but they want technology that's going to make their jobs better, simpler, easier, but also benefiting the patient. And so we will sit down with residents and have conversations on technology that they've seen, technology that they've heard about. You speak of AI, they're worried about AI. They're worried, will somebody take over AI, 1 or 2 people, and then control it? You know, they're worried about, can AI become a negative thing? And so we've had them involved in discussions on, well, what do you think we can do with AI? What do you think we can do with robotics? So we use a lot of innovation and technology, even with our EHR, again, for great patient care, but also too, to integrate our residents and our fellows into our development, because at the end of the day, that's how we're gonna have better health care, by having this next generation at the table designing what we think is gonna be great technology. Without them at the table, we've found that we usually miss the mark.
Yeah. And Joyce, what about you? How are the nurse practitioners thinking about technology?
So we have for many years been using telehealth because many of us practice in rural and community health centers. And so we've been looking for innovative ways to use telemedicine, telehealth. I used to practice in one community health center that before people knew what it was, we were using it because we needed to have access to people in rural areas that couldn't come in. And I practice in southwestern Pennsylvania, West Virginia. So if you know it's mountainous, it's treacherous roads, difficult for people to get access. And I think that at AANP, we have had people come to conferences, speakers, early on to get people comfortable. I kind of was laughing about the AI to myself because I'm a professor at GW of nursing, and I'm on a large university-wide committee and on the technology committee. And they were talking about how are they going to get people not to use AI. We shouldn't have it in our, and I'm like slinking down in my chair, and I'm on, thank goodness, on a Zoom call, thinking, well, I already put those assignments in my work 2 years ago, and you're just talking about it now, you know. So I think there's a lot of precautions that we need to take with them. We're talking about that within our organization, how we can use it effectively. I think in terms of workload, for providers and for the staff, I think this is going to be a great innovation if we know how to use it properly. But what I tell the students is bad information in, bad information out. And you still need to have your brain to be able to decide which is good information and which is incorrect information. And so I think we have a big learning curve with that in every profession to look at how we're going to use it. But I think for primary care, I think this is going to be something that could help us improve our access, and I think that's going to be huge for all of us.
Yeah, you know, you mentioned telehealth. All of you have mentioned telehealth. I think, you know, over the pandemic, about 13%, prior to the pandemic, about 13% of our members reported using telehealth, and by May of 2020, that was up to 94%. So I think going forward, we really had to rethink how do we incorporate this into our ongoing learning for our members, and it sounds like all of you have faced similar questions. I'm going to stay on Zoom for a second. I would imagine actually because of COVID, it changed the way that you might reach out and recruit people to join your organizations. Can you talk a little bit about those efforts and maybe the pluses and minuses and lessons learned along the way? Let's see, who wants to go first?
Well,
Joyce? Yeah.
We have started early on an organization to use Zoom to reach out when we started noticing our numbers sometimes going down for conferences and so forth because of the cost related to it. So we started to use other mechanisms to get continuing education credits for our nurse practitioners. And then that kind of developed into more use of meeting time. You don't have to bring your whole board in all the time and pay for that so you can meet on boards. But I think we also used it to recruit members to be part of different task force, different specialty groups within our organization, and that's been very effective because they've been able to work together to talk about their issues. We have a robust primary care group, a robust rural health care group, a frontier NP group that are working together to solve issues that they're seeing in their practices. So we started early on with that, and I also think during COVID, having that experience, our nursing department was able to help not only nursing but other schools at GW put their information online because we have been doing it and we knew how to do it. And so we do our student interviews that way. So we have, a lot of mechanisms using the technology. But again, I think the key word is using it wisely and how to use it to your best advantage.
Yeah, it's been a gift and a curse. I think it's conserved a lot of resources in terms of travel and kind of vetting out that early on process. Similarly, we've done a lot of CME programs to engage our community, our adjunct faculty, and we've really gotten great participation and a lot of great ideas. LinkedIn has been really huge, and we don't get to go to the conferences as much, and we noticed that similarly participation had gone down. But offering people the hybrid model, I think, is something that's going to sustain itself for quite some time. We recently had a search, and we did 13 interviews in maybe 3 days, and the first round was all virtual. And we were able to see certain things, and I tell you, when we met some of the people we invited to campus, we were talking about it earlier, it was very different seeing them in person. You miss some of the other things that you can see when you can look a person in the face and read the room and their facial gestures, and it helped us to cut that list pretty quickly. So it's a gift and a curse, but I think it's here to stay. And I think much like the AI conversation, the telemedicine conversation, we need to lean into it a little bit and just kind of work through the cons, but focus on the pros.
And again, from the graduate medical point of view, first of all, during COVID, we had to teach our residents how to do telemedicine. So we have a curriculum that they called us the more seasoned doctors, of how do you talk to a patient through telemed. Because just because they can be on the computers doesn't mean they know how to talk to people. So we did great with that. And then we got into a hybrid model. And we found that particularly for medical students, and those of you who have not been in training, medical students have to pay to fly out to all these places to interview. They have to stay in hotels. So the average medical student can spend $4,000 to $5,000 a year to interview, because programs no longer can pay for you to come. And so we offer a hybrid model, but we taught our residents and we taught our faculty how to interview through that model. So you're giving people a fair shot, whether they're in person and they're on WebEx or Zoom. Also, too, we got our residents engaged, because how do you see your hospital if you're not there? So that's where the residents got to put their social media skills. We let them loose in the hospital, and they made these little mini videos of my hospital, the life and the day of Sherri Morgan, the resident. So we got the residents engaged that way, working with our marketing teams to make sure there was nothing on there that I was going to have to write a letter about to somebody. But they got them engaged. And so it's worked great in terms of our recruitment for residents, but also too on our physician recruitment side, they did the same thing. They were using WebEx and Zoom, but then they realized, well, wait a minute, the residents came up with this innovative way of marketing the hospitals. They start using some of that. And then we've carried that forward to get them ready for when they're interviewing for jobs, because the same thing. Most people are doing a WebEx. If you're going to look for a job outside of where you live, they're not flying you out there the first time. They want to do a WebEx interview. So we're getting our senior resident fellows ready for those interviews by teaching them how to interview by WebEx, interview by Zoom, so they can then go out there and maybe get that second or third interview. So it's really helped us a lot. But again, I keep bringing it back into everything we do is about for getting our residents and fellows ready for not just training, but for the world afterwards. But then this great generation has helped us take some of those ideas and use it with what I call our doctors who are already out there practicing on the rest of the organization.
Thank you. You know, in thinking about growing the workforce to meet the needs of people and populations, I think core to that is making sure that you are growing a workforce that is reflective of the community. And so I'd like to move on to talk a little bit about how your organizations are approaching diversity in your workforce efforts, inclusivity, and making sure that you're cultivating a workforce that represents the community. Joyce, I'll start with you.
Well, at AANP, we've been really working hard on our diversity, inclusion, justice issues within our organizations, and then pushing that out through our other sister organizations to really understand the impact of it. I think because many of our programs are community-based programs, so we encourage students to stay in their community. And then most of our education is hybrid, so they can stay within their community. They usually have preceptorships within their community. And so they are part of the community, have the culture in the community. And then we're working hard to bring up from people that we notice or want to be nurse practitioners from various cultures into it, because we know that people want someone who looks like them or acts like them or at least understands their culture. I tell the story, I live in south of Pittsburgh, and my clinic where I was at the time, a community health center, was right on the West Virginia, Pennsylvania border. So literally 1 foot on north of the Mason-Dixon line and 1 foot south of the Mason-Dixon line. So I came in and a woman said, "Where's the other provider?" I said, "She's not here today." "I don't want to see you. You're a Yankee." I was like, "What?" Like, I'm still in Pennsylvania. What, you know? And so I think she didn't think that I understood her culture, really, you know. And it just so happened that day I had a shirt on that had Elvis on it, and she said, "Oh, you have an Elvis shirt. You like Elvis?" I said, "Oh yeah, my mother loved him." And so then I was okay. So I mean, as part of understanding the culture that you're working with and what you bring, you know, what you bring to it. But I think we really have to be stewards of our professions to bring up people who may think this is not for them. Like, I didn't know what I didn't know what I was going to do. I grew up in a housing project, you know, like just getting out of high school was like a feat, right? So you don't know what you're going to do. And then when I was president of a rural school board, I wondered why everybody just wanted to be a teacher. And then I realized the only college-educated role models they had were teachers. So I said to my neighbor physician and some other people, I said, "Let's go to the high school and have a job fair, and all of the professionals come so they could see that there's more advantages than just being a teacher." And most of them weren't really familiar. And so I think we have to do a lot of work to not only talk about primary care and the importance of, but how you get into it from the very beginning and the impact that you can make in your communities.
I really loved that story when I heard you tell it, because, you know, it seems so obvious, but I think we overlook the fact, you know, we're always thinking about how do we bring the workforce to the communities when really a lot of it is there, and allowing people to see themselves in it, I think, is really important. Millard?
You know, studies show that patients have better outcomes when they're treated by people who look like them, or at least are culturally competent. You know, and Meharry's a historically black college and university, and when I started my journey in 1997, 5% of the nation's physicians were black. Today, it's still stagnant at 5%, despite making 13% of the population. So how do we address that? For many healthcare organizations, Meharry is the nation's answer to healthcare workforce diversity. And we take it to the community. We've adopted 2 middle schools, and we let them see it. Most often, you know, young kids in urban areas just don't dream anymore to be a physician. You know, they're trying to live life and survive in many ways. But we've fostered mentorship, and we've done some things. Something else that, excuse me, I thought of in 2010, and it's by no means a novel concept. I was a Harvard Macy Scholar in 2010, and I had a project. And I looked at maybe shaving a year off medical education, and instead of making it 4 years, make it 3 years. And what the study showed was that people were more likely to go into primary care because they didn't have that need to go out and earn a lot of money. And they're more likely to go to academic medical schools as well. Well, we are in year 5 of a partnership with MTSU and Meharry, where the students actually come over early on and get some medical school credit. And it's totally funded, and as a result, they're going to go into rural communities to pay it back. We have to have more innovation to do that, and what I find is when you have certain programs like that, a lot of times young kids don't look at those programs, but the mature nurse who really wants to maybe elevate her involvement in healthcare and be a provider, or someone else who's been affiliated but didn't think it was for them. And we have to really try to find the right people who are primary care minded and shave off that the liability of medical education and incentivize them in order to get it. If we can do that, then I think we can address the healthcare outcomes. Finally, I think we need to really lean on the payers. I may have said that already, but if we lean on the payers to really appreciate those that are taking chances on high-risk populations and improve the reimbursement models for primary care physicians, then I think it will return its luster.
Thank you. Sherri?
You know, being a family medicine physician, the reason why I did family medicine versus OB was because of mentorship. Medicine wasn't my first career. I had a master's in public health. I was doing health services in the New York, New Jersey area, and came back to Columbus, Ohio, and was working with some family physicians designing a community program that wasn't working, and they're like, we need family physicians. I said, but I like delivering babies. They're like, you can do that too. So, you know, I decided to go to Wright State, School of Medicine, which was primary care focused. And I say that because everybody around me talked positively about family medicine. I didn't hear all the horror stories about you can't make money. It was always positivity and how you need to also be at the table. So when I went to medical school, my mentors pulled me along with them to meetings at different levels of organizations to learn the business side of medicine, to learn the organizational side. And so by the time I got into residency, I was ready to not just be a family medicine physician, but to fight for family medicine. I think we have to do a better job of really selling how to make a difference in family medicine. I talked to a lot of residents who are in family medicine, and they say, you know what, I loved working with Dr. Morgan during this rotation, but all the things she complained about all the time was she's not getting paid. She's a great teacher, but she complained about this, and do you know how terrible the EHR is? And I'm like, it tells me that we've got to find a way to take all that information you presented and find a way not to candy code it, but to say, okay, we need to be proactive and get this next generation at the table. This generation is very smart, they're very active. And so if we want the payers to treat us better, we have to start helping them. Say when they're going through residency, I have residents who I've talked them into doing some Masters in Health Services or MBAs. I've got some very highly intelligent family medicine residents who are wired to think like CFOs. And so they're pursuing an MBA while they're getting their family medicine. They'll be the ones to fight the providers, the insurers. That's what they're going to probably end up doing. They'll be FM docs. And so what I try to do in my role as mentoring is, if you want to make a difference, let's get you at the table. And let me give you something to do to help family medicine. And what I hear back from the residents are, we don't need to hear any more horror stories. We need for you to tell us what can we do to turn this around. This generation wants to fix it. I learned that during COVID. We had a bunch of internal medicine residents. Everybody has order sets in the hospital. 3 o'clock in the morning, I was a DIO. I got a call, and I wasn't seeing patients. So at 3 o'clock in the morning, I thought, okay, somebody's in trouble. No. A couple of IM residents that came up with a brand new order set on how to handle COVID patients. I'm like, okay, we're going to have you present it to the MEC. Do you know, a month later, they changed the order set. Those are 3 IM physicians now who are on medical staff at that same hospital who are making change. Another example of, if you lead them to the table, get them involved, we can make a difference. And so that's what I think we have to do with primary care is they're out there, they want to do it, but what scares them right now, I have conversations scheduled next week. Should I stay in family medicine? Because I just read another article how we don't get paid. And what I tell them is, yes, you need to stay in, but I'm going to link you up to somebody who can teach you how to code better or teach you how to document better. But I also want you involved in negotiations or working with insurers. So we got to get them involved. I'm a kid of the 60s, I'm telling my age. So I was raised by parents of the 60s and late 50s, and civil rights and all that, and we just didn't sit back and wait for somebody to fix it, we fixed it. Let's do the same thing with this next generation, and I think we can turn it around. I think we can make your numbers look a lot better in a couple of years, because they're still out there. They just need the permission to kick the door in and do something different. And I told them do it. And I have conversations with them all the time. Even at HCA Healthcare, we are making change in family medicine.
All right, that's our new tagline, growing the primary care workforce, kick the door in.
But if you think about everything they've gone through, and I don't want to go, but this generation has gone through not fire drills or tornado drills, but duck drills. Look out for gun. We've taught them how to be proactive and how to think defensively. Take all that energy. Look at how they handle COVID. Let's put them to work in saving primary care. There's a whole ton of them out there. I mean, we filled all our family medicine programs. And they're coming in, but we got to teach them how to make a difference in primary care. I tell them they got to take care of me when I'm ready to retire. So I want them all to be ready so they can keep me happy in my little nursing home or wherever it is they're going to put me. But I want primary care to be successful, and I want to know that was my mark, that family medicine was okay, in the next 5 or 10 years, because it can't go anywhere.
Yeah.
But we got to fix it.
Well, you may have actually answered my last question, which is, what gives you hope from this, our interest in growing the workforce? What are the signs and signals out in the environment that give you hope that we're going to get there? Joyce, can I start with you?
Well, I have hope that even though we had a little slack, I guess, in the amount of people coming into nursing, I think there was the, you're a nurse hero, but then you're also like overworked and overtired. A lot of people were leaving nursing, and we're dependent upon nurses to come in to advanced practice nursing. But I do see a more of a trend for younger people to be interested in nursing, and also to be interested in the advanced practice role. I have a lot of concerns about the funding that's happening at the national education level for college, so we'll have to all keep an eye on what's going on there, because that's going to really impact the workforce that's coming in. But I think we're seeing, for nursing, brighter people coming in that want to make change, that know how to use the technology. And so I'm kind of excited about that. We still have a nursing faculty shortage, so we have some work to do in that area to ensure that our workforce continues. But I'm optimistic, as we discussed, about the new people coming in and what kind of workforce we can have from that they bring to the picture. And I think also increasing our number of men, minorities, and other people into our workforce is important. In our one clinic, we had 2 people that came, we trained as medical assistants, and we sent them to RN school. That was huge. That was huge for that community to have those professionals come in. So I think we have to look at alternative models also to bring people in.
Well, I'm a Meharian, and I'm a bit of a half full kind of a person and a tad bit cheesy. So I'm hopeful. I'm hopeful for a lot of reasons. I'm hopeful because we're having this conversation. I'm hopeful because of the need that we see that is still there, and the statistics are still getting greater and greater. I'm hopeful for all the reasons, all the partners that are aligning with primary care to try to advance it and decrease that medical education costs, HRSA. And I'm hopeful for the AAFP, for what we've been doing. I've been hearing the AAFP for a while, and as a student, it didn't mean much. But once I became board certified and started to get a good feeling, and I started going to conferences, you see a lot of people who think like you do. I may have failed to mention, we have a residency program. I was a program director for 8 years, and you stimulate a lot. I'm hopeful because of Dr. Morgan and her passion and the fact that she has the ability to touch this next generation. When these kids can actually see that positivity that Dr. Morgan was mentioning, many of them go into family medicine because all of the things that they say are just not true. I'm a geriatrician as well, and I show them that ways in which you can actually make a difference and refer patients to your home organization for the hospital service, that continuity, limiting the need for overhead, and being able to go in and see these patients, and generating various ways to generate revenue to still be a primary care physician and do what you want to do. We do a lot of fellowships in family medicine as well, and addiction is something that is paying them money. They're being hospitalists, and I'm hopeful that the more exposure that we can get to these young kids and still screen them on the front end to make sure that they're coming to medical school, at least at our school where we are a primary care school, for the right reasons, I'm always going to be hopeful.
Thank you. And I guess, I would say I'm very hopeful because there is a generation that still wants to do family medicine and primary care. I am a peds. This generation they're not lazy, they're not spoiled, they're not selfish. They're like, show me, prove it. They're the show me generation. My grandfather told me once, everything comes back around, and they don't believe everything they read, they want to see it. And so we need to show them, and we need to surround them with people who are going to be very realistic about primary care and what it takes to be successful now and how we can make it better. And I think we'll get there. I mean, I have some really great, I'm an old PD, and I have some great program directors. And one thing about our programs, we have the right people in the right roles. And we hire graduates. And so my goal as being in GME is to make sure the right people are the right villages surrounding these students, to make them realize that primary care is womb to tomb. Old mentor of mine still has that on his license plate, womb to tomb, and we can do anything and everything. You don't have to do everything, but you can. And so we just have to make sure that we all work together and help them realize more how partnerships, again, with other health providers, can help make their job better. And last but not least, my job is to make sure when they graduate, they're ready to be successful, not just financially, but well-being, work-life balance, picking the right practice, picking the right environment, get to know your community. So I have a friend who retired when she was 50 from family medicine, 50 years old, because she got burned out at 50. She got 4 kids, but family medicine burned her out. So I don't want to see that anymore. So we got to make sure we've got that work-life balance for them. So I think we'll get there. We just have to keep talking about it and putting action into it. And maybe the next event, inviting some of them here and getting their opinion, because I think keeping them at the table is the best way to do it. So. But thank you for having this. Was great.
I just want to thank you all for all the work you're doing in your respective organizations and your commitment to primary care. So please join me in thanking our panelists.